Hello, good afternoon, and welcome to this afternoon's session around connecting system-level data to improve care and population health insight across Greater Manchester. So many thanks for joining us. Just whilst we're waiting for other attendees to join, a couple of housekeeping comments. One, this session is going to be recorded, so it's being recorded just now, so I hope that's okay with everybody. And for the Q&A, we'll keep some time for a good Q&A and discussion with the audience towards the end of the session. So please, could you use the chat function just to put any comments or any questions that you'd like to put forward. Thank you very much. So, as I said, welcome to this session. My name is Douglas Clark, and I'm the Head of Medical Affairs at Boehringer Ingelheim. Now, I've been with Boehringer Ingelheim for just over 8 years. And prior to my current role in the UK and Ireland, I was in the corporate headquarters in Germany. And one of the things that really struck me when I returned to the UK at the beginning of the year is, how my passion for implementation of scientific innovation has been fueled by the data-rich and connected data-rich environment which we have in the UK. And how that empowers improvements in patient care and in population health care and improvement of outcomes. So it really is a great pleasure to be here today and to be moderating this discussion with Guy Lucky, who is the Digital Innovation Director at Health Innovation Manchester. So Guy, welcome. Perhaps we could start off with you telling us a little bit about yourself, your current role, and your journey to the current role.
Yeah, no, absolutely. Hey, just first of all, just to say thanks for the introduction, Doug, and it's a real honour to be part of today's conference programme. Just as way of brief background, I'm born and bred in Greater Manchester, went to university in Salford and spent about 25 years of my career working for a global tech company, helping and shape and lead some of the largest and most complex digitally enabled healthcare transformation programs, both in the NHS and across the world. And sort of through this experience, I've seen at first hand the power that digital can bring to bear, addressing some of the wicked challenges we face in healthcare, and in turn really transform patient outcomes. That said, there are two key ingredients I believe are critical for success. One is, first of all, to gain absolute clarity on the problem we're trying to solve, and less focus on the tech, and that the solution to that problem is much broader than the tech and involves people, process, and cultural change to be successful. And as a sort of rule of thumb, if you spend £1 on technology, we should be spending £3 on the organisational change, adoption, and to embrace that technology successfully. So whilst working for that global tech company, I always felt one step removed from truly understanding the problems at the front line, and really the ability to champion the people, process, and cultural change required. And it's for that reason I stepped out of that world and to get closer to the action and to the patient. I'm now privileged to be part of the NHS and working for Health Innovation Manchester. And in Health Innovation Manchester, I have two roles. I am Digital Innovation Director of Health Innovation Manchester itself, which includes an academic health science centre and a network. I'm also the Digital Innovation Director for GM Integrated Care System.
Brilliant, thank you. It's great to hear in your introduction just pulling out those two kind of critical elements for success, and that really focusing on the problem and ensuring that that end user, that the patients are really part of the solution, and it's not just about the tech, it's the people, it's the environment, it's all that goes around with that. Maybe you can start by giving us a bit of an overview on the Greater Manchester and Healthcare Innovation Manchester's ambition and mission, and the role that you're playing in that in shaping that digital program.
Yeah, no, absolutely. So perhaps I'll just start as a bit of a background around devolution, the drive and devolution in GM, and how that came about, and the role of Health Innovation Manchester within that devolution journey, and then the role of Health Innovation Manchester in helping coordinate the digital response within Greater Manchester. So Greater Manchester, like many other parts of the UK, as a diverse population with a range of very complex health needs, and these range from sort of below average life expectancy for both men and women to an aging population and children facing disadvantage from an early years. And all the while, public services are faced with unprecedented demands and stretched resources. So this was sort of recognised about 5 years ago as part of the devolution journey of GM, where GM leaders recognised that the poor health of the population was preventing people from being able to work, which in turn was impacting on economic growth and prosperity. Therefore, in 2016, GM became the first fully devolved city region, which was a major catalyst for change. Through devolution, GM leaders have delegated responsibility for the 6.6 billion health and care budget, and through integrated commissioning at city and locality level, with the ability to commission and deliver different types of services. So within that context, Health Innovation Manchester was formed to directly respond to the challenge of poor population health. We work at the intersection between health and care, academia and industry, and our role really is to discover, develop and deploy new innovations into frontline care to improve the health of our 3 million population within Greater Manchester. So since joining Health Innovation, Since joining Health Innovation Manchester about 2 years ago, we've really focused on developing our innovation pipeline approach to deliver transformational change, which involves gaining a real deep understanding of citizen need, clearly defining the problems we want to solve, and co-creating innovative solutions, often in direct partnership with industry. We've also evolved our operating model to ensure we have the right blend of skills and capabilities needed to operate a digital office that provides digital strategy, design, development and deployment expertise across the system for the ICS. As we zoom into from a digital perspective in particular, over the last 2 years, we've done a tremendous amount of work. We've refreshed the GM Health and Social Care digital strategy, so to ensure it is absolutely subservient, but informs our response to the NHS long-term plan and our local industrial strategy. We've established a digital transformation board comprised of clinical, provider, financial and digital leaders across the system to ensure that digital is owned at the top of the shop within the Greater Manchester ICS. And we've also co-created an integrated care system-wide digital investment and maturity framework to identify prioritised programmes of work to deliver that strategy. And through that process, we've worked with over 120 stakeholders, including patients, public, health and care staff, where we've first of all identified the pain points and opportunities for improvement within existing pathways. And then we've looked to reimagine those pathways through a digital lens to realise those opportunities. This has helped us then identify 47 digital data capabilities required to deliver our ambition. And then for each of these capabilities, we've defined a 5-point maturity scale and identified where in the scale we need to be. And we've set 2 targets for each of these capabilities. One is a foundational target, which is the minimum that we need to get to minimize risk. And the second target is an aspirational level where we really need to get to achieve our healthcare outcomes. And then what we've done is work with all our ICS stakeholders to determine what their current level of maturity is against that scale. And those ingredients then enable us to understand where we need to focus to be able to get to either foundational level or aspirational level, and the investment required to be able to deliver on that agenda. And that piece of work has been really transformational in terms of joining clinical with digital people, with finance people in a co-creation environment like we've never seen before. And I think that's been a real key ingredient for success. Also, over the last 2 years, we've delivered a plethora of digital transformation programs that have had a real impact on frontline services.
No, really interesting. And perhaps we can come back to, if the time allows at the end as well, on that kind of capability and upskilling and how you bring different people and groups together to ensure that there's a common language and understanding around sort of digital and application of it as well.
Absolutely.
So, it wouldn't be a session without at least alluding to the pandemic and the challenges that COVID brought. Obviously, this has changed kind of all of our lives, and perhaps you can share a little bit about your experience and how digital has helped you respond in Manchester to these challenges over the past 18 months or so.
Yeah, I absolutely no question, no conference is right without talking in respect to the current COVID crisis. from a digital perspective, I think we've seen a massive acceleration of digital activity over the last 18 months. Largely driven obviously by the crisis and the need to really do things differently, and to think how we deliver services in a different way. From a GM perspective, I'll just give you a flavour of the activity that we've been involved in. And when we say we, this is the greater we in terms of the overall GM digital capability across GM. So not just me and my team, but from as part of the COVID crisis, the huge amount of effort went up to set up the Nightingale Hospital within the GMEX Centre and put all the IT infrastructure in place to enable that to work. A huge amount of effort went in to support remote working for hundreds of thousands of staff across all our care settings. So a massive program of work around remote working, which will set us in great stead for continued flexible working patterns. A huge focus on delivery of virtual consultation for both primary and secondary care, and a deep focus on understanding about how we move to a clinical triage-led primary care offer, and the need to really change your working practice really to build on the capabilities the technology provides you. We've accelerated at pace the GM Care Record, the shared integrated care record for both direct care and population health, and that GM Care Record is really seen as a transformational digital asset to really help us transform future clinical pathways. We've also developed a brand new and launched a digital platform to support stop smoking services for those that smoke during pregnancy. That has been another major transformational piece of work which supports the frontline midwifery teams to go out and remotely manage pregnant women that are smoking. And we're also working with the national team about how we can scale that platform more broadly than Greater Manchester. We've done a significant amount of work around how we support the care homes. Obviously, care homes have been, particularly affected by the COVID crisis. So very early on, we worked with one of our strategic partners to pivot their current sort of digital offering to be much more focused around how we do remote monitoring of care home residents, and to then develop or deploy a clinical service around that monitoring. So what that really meant was that the care home staff could do a very simple soft signs assessment of deterioration for care home residents every morning, and that assessment went through to a clinical hub, and that clinical hub then reviewed that assessment and proactively reached out to residents as required with, and again, a huge amount of impact has been delivered from that platform. We've delivered a emergency care a system by appointment. So we've established a GM clinical clinical assessment service, which is an early exit from 111. So if you phone 111, you will, if you're a GM resident, you will get directed to our clinical assessment service. Where you'll go through a more deeper clinical triage, and in that clinical assessment service, we've enabled the direct booking from that clinical assessment service directly into the front door of A&E. We've also put a consistent digital front door across all our A&E departments. So when you come into A&E, you go through the same triage process that you would do if you phoned up the 311 into the clinical assessment service, and then that redirects you to the most appropriate services, including booking you directly if it's not appropriate for you to go to A&E, into a GP appointment or into a same-day emergency appointment, or indeed continue on into A&E again. So that's been transformational. We've also deployed a booking system for the COVID vaccination for all our staff. So over 300,000 staff within GM. So we've deployed a single booking system, which has enabled us to balance where staff go and give them the freedom to get their vaccination, the COVID vaccination at pace. And we've also deployed a range of digital support tools to support at-risk groups, especially with mental health challenges. So that just gives you a quick whistle-stop tour of the items that we've really sort of focused on. And I suppose finally, we've really sort of set the stage about what we do with population health in terms of the collection of some very rich data set. And I'll talk more about how we use that data moving forward.
Yeah, no, that would be great. I mean, I guess the speed of change has been incredible. And I'm sure there've been some challenges as part of that, and perhaps we can come back to have a chat around some of those as well. You mentioned it earlier. You mentioned the creation of the General Manchester Care Record. I guess that's been a kind of critical step forward as part of this process. I'd love to understand a little bit more about how you went about kind of accelerating that creation, um, and sort of the infrastructure set up behind that.
Yeah, no, absolutely. So just to give you a pen picture about what the integrated care record is. So it's an integrated care record for Greater Manchester patients that brings together patient data from primary care, from GP practices, from community, from secondary care, from mental health, from specialist services, for example, the Christie Cancer Service, social care and NWAS into a single record. And in that record, it brings together all the key information around that patient, including diagnosis information, medication information, test results, hospital appointments, attendances, care plans, your end of life wishes. So rich data set, and also your next relationship, so your family network as well. So what does this sort of mean from a patient perspective? That integrated care record now, which is now available at all points of access around Greater Manchester. So whether you go into your GP surgery, that's available, or you go to an A&E department, that's available there, or if you go into social care, that's available there. So that service is now available across the whole of the Greater Manchester care and social care settings. And what it really enables from a clinician perspective, it enables them to have easy access to all the patient information that enables them to make decisions effectively and quickly with all the relevant information. It also is enabling us to create multi-agency care plans where the care of individuals is actually serviced by multiple different organisations, with including GPs, primary care and social care teams, and provides a platform to be able to have an integrated view of that care plan for that individual. And the rich data that's being created is also enabling clinicians and operational planners really to identify patterns and plan care more effectively, which is crucially important. And then, from a patient perspective, what it really means is you don't have to keep repeating your story, your medical history to every single clinical profession you meet. So, and what we've seen is some really sort of transformational sort of stories about how that GM care record has really enabled and protected and accelerated care at pace. And from an operational perspective, just in terms of the efficiency that's driven by the use of that care record, we're seeing on average around a 30-minute saving of time per clinician that uses that sort of platform. So not only is it delivering much more effective care with information being at the fingertips of clinicians, it enables patients to be able to only tell their story once. It's also saving clinician time. So it's a win all round. In terms of what we've done over the last 2 years to accelerate the GM care record, I'll just give you a pen picture of how the GM care record came about, and then the work that we've done over the last 2 years to accelerate it. So Greater Manchester is comprised of 10 separate localities, and each of those localities essentially created a version of their own care plan for their own locality. And they created it on the same technology platform from our partner GraphNet. Those individual databases, if you will, have all been moved into a single database. But before COVID, we had around about 2/3 of the GM patient records on that platform, but there were still walls in the data. So what that really meant was that if you were a Salford clinician, you could only see Salford patient records. So if a Manchester patient came into Salford, the Salford clinician couldn't see the Manchester patient's record. So over the last 18 months, we've truly accelerated the the deployment of that capability. So we've removed all the walls in the data to enable cross-organizational data sharing, and we've done some real heavy lifting around the information governance and building trust in the system around how we've executed on that. Almost all the data is being shared now. So I think we've got 99.9% of all the patient records across Greater Manchester on that platform. And we've doubled the clinical usage over the last 18 months. So we've seen a dramatic increase in clinical uses. And just to give you a feel, we see around 5,000 accesses to that patient record every day. So, you know, a huge transformation has gone underway. And now we're jointly working with both the clinical and academic community to undertake real vital research around COVID-19 using the GM Care record data, which is really helping us to understand the epidemiology of the disease and be able to target the most vulnerable groups in a much more effective way. So, you know, huge, big transformational change for Greater Manchester. You know, the frontline staff love it, the system loves it, and the patients really need it. So it's a really sort of powerful story. I think in terms of, you know, just answering the question about how we got there in terms of the acceleration that we've managed to do over the last 18 months, I think, you know, the COVID crisis has enabled us to, I suppose, be laser focused on getting alignment about solving problems. And that's been a real key ingredient in success, getting system alignment to go, this is important, let's get this done. And then in terms of the ability for us to execute at pace, the key thing is how we've worked with the whole system, all the data controllers to build the right information governance, ensuring complete open transparency and trust around data usage with patients and the public, and engaging them in that process. And then, you know, working from a technical perspective, hand in hand with our partner GraphNet and all our regional digital teams, where we leave your badge at the door, and we ran daily agile sprint stand-ups to ensure that we'd get all the data feeds completed, all the walls in the data removed, which is essentially enabled us to accelerate to a completely different level from where we were prior to COVID.
And you know, you've nicely outlined the benefits from a patient perspective, and also from a clinical provider perspective, in terms of things like, you know, the access and even the saved time. Perhaps you can say a few words on how we can evolve from use of that care record being one that empowers information sharing, to one that can also support and drive innovation, research, and transformation of care.
Yeah, absolutely. So, you know, over the last 18 months, I think we've built a fabric, or a key asset that really is an enabler for both population health insight and also transformation. So what this is enabling us to do, really, if I zoom into the analytics space in particular, so within the GM Care record, there is around about 7 billion rows of data, so vast amounts of data that is all operating now on a cloud platform, which enables us to utilize all the capability, both in terms of the infrastructure burst out capability, and also machine learning algorithms to really understand causality in that data. So as part of that, as part of the work that we're doing under the coping notice with respect to COVID-19, what this has enabled us to do is to have a rich data set to be able to do that data mining, to understand the epidemiology of the disease, and also to ensure that we're targeting the most vulnerable groups with the most important interventions. And as part of that, we've established a secondary usage oversight and scrutiny group. And what that group is there to do, really, is to provide absolute transparency around the use cases, around the use of that data. And we've got a whole, in partnership with all our academic partners within GM, of which we've got 4 great universities within Greater Manchester, we are now operating a pipeline of research studies, of which we've got about 25 active research studies specifically around COVID-19, actually operating and working on that data. So there's lots of work that's been going on in terms of how we're planning and are currently using the data. It's identifying people with or at risk of COVID-19. It's been able to cohort segment the COVID, people that need to have burst level testing within particular regions. So we identify hotspots to challenges where we see positive COVID cases rising. As I say, we've launched a number of research studies to better understand the epidemiology of the disease, and it's got 25 studies underway. And finally, we're looking about how we can use that to actually focus on clinical trials to support the COVID-19 response. Now, the key thing really is with all analytics is is ensuring absolute transparency of data usage and making sure the patient and public and all data controllers are absolutely fully understanding how that data is being used, and can't overestimate the value of building trust with those groups and the need to maintain that trust and transparency to be successful. The second key thing is how you take that insight and drive it into action. So one of the key things that we're working through now is how you drive that insight, if you identify something at risk, directly into activity, into the workflow of clinicians. So if you're running an algorithm to identify specific, the patients with complex comorbidity that are being really affected by the disease, and you want to target specific GPs to call out to their specific patients, how do we actually insert that call out notification directly from the analytics directly into the patient's GP so they can take action? So that's a key focus for us to moving forward. Above and beyond the analytics, we are using the platform to deliver a number of key transformational agenda items. So we will be deploying a GM care record to the whole population with Greater Manchester. So you will be able to have access to your integrated record. So that program will start rolling out probably from October onwards. We are providing a lot of focus around multi-agency care planning, and we're focused on a number of different areas. I'll just call out a few. One is, how do we create an integrated heart failure care plan? So there's 40,000 people in Greater Manchester with heart failure. How do we ensure that we co-create that integrated heart failure care plan so it can be shared by both secondary care and primary care? We're also deploying a frailty and dementia plan, so an integrated plan. And again, frailty and dementia is another good example where you need to have an integrated operating model of health and social care services, so where you're collaborating as an MDT. And the final element we're collaborating on is really the use of an end-of-life care plan. So we're really clear about end-of-life wishes and ensuring that every point that care is administered, that people understand those wishes. So if you're in the ambulance, then what is your preferred wishes? So what we don't want to do is take patients to hospital if their preference is not to go to hospital, as an example. And then we are focused on a lot of activity around remote monitoring. So we've deployed a COVID remote monitoring solution. So for those patients that are greatest risk of suffering from COVID-19, then essentially we onboard them with a digital app and deploy blood pressure monitors and O2 saturation monitors, and we actively remotely monitor to those patients, and that remote management is proactively monitored by a clinical service. So if people see anybody deteriorating, they'll proactively reach out to those teams. We've also deployed a similar remote monitoring application to patients that pregnant ladies that are at risk of preeclampsia and gestational diabetes. So we actively monitor their blood pressure, we actively monitor their glucose rates remotely. And again, there's a clinical service that actively proactively reaches out where appropriate. We're doing something similar around rheumatoid arthritis and symptom tracking to understand the impact of pain with respect to different conditions. So how does weather, for example, affect your levels of pain, and how does that flow into the GM care record, so we can understand that in more detail. And we're doing similar projects around diabetes and childhood asthma monitoring, all with remote tools that feed into the GM care record and then activate outwards to those relevant care settings. And then we're doing some work around meds optimization. So, a big focus area is making sure that people are on the right medications. So how do we ensure that everybody's got access to the medications? So if you're in primary care, where most of your medications defined, you go into secondary care, that information's there at your fingertips, so that the secondary care consultant doesn't have to ask the individual to remember that long list. And underneath that, is that patient really on the right medication? And then finally, what we're doing is focus on how we streamline operational services. So a lot of focusing around the handover process between secondary care discharge, for example, into social care, and making sure that we remove the paper handover processes in that process. So hopefully that gives you a flavour of what we're doing at the analytics level, and also the transformational pathway level, where we're changing the way that we work.
No, absolutely. Some really tangible examples of this, how you're bringing this through. There's been a couple of questions that have come in, and I think a few of them sort of relate directly to what you've been discussing. There's a couple around the theme of, what you should be doing in terms of reassurance, or is there a role to play in education around how data is used, given the current sort of very public discussion around use of data, use of care records, and around governance.
Yeah, no, absolutely. It's a great point and very, very timely. So interesting, I think, from the research that we've done, most patients think we share the data within healthcare between ourselves, and so they're surprised when we're not. In terms of how we've approached this very sensitive area, the key is absolutely having complete transparency with public and patients about how that data is being used. So I mentioned before the forums that we've established. So we've established a secondary uses oversight committee that's got patient and public involvement in, where every use case that's using that particular data, not for direct care purposes, is actually approved with the full, with patient and public representation on that board and representation from all data controllers. So that has been absolutely sort of fundamental in terms of building some governance infrastructure that enables that to occur. We're also, because we're doing a lot around the GM care record, we're launching a specific comms campaign over the, I think it's been launched over the next few days, where we really engage, with each data controller type, so the GPs, with secondary care, and with patient and the public, around explaining what the GM care record is, what it means to them individually, and the value that they get from that sort of data sharing. But yeah, short and answer the question is absolute transparency at all levels about how you're using that data in a very auditable way is absolutely fundamental. And the key thing that we've driven is, I can't overstate the importance of building trust with data controllers and the patient and public. And the moment you lose that trust, then it's like a house of cards, everything will fall from it. So we spent a lot of time structurally getting that trust framework in place. So we systematically build that trust in through defined governance structures that we've put across Greater Manchester.
No, a really topical and really important topic. Another couple of questions relate to geographical boundaries, and how you're dealing with geographic boundaries in terms of access to the shared care record, and I guess more widely, how you've ensured that clinical information can be shared safely amongst physicians and clinicians.
Yeah, so with respect to the first question, so if we look, for example, in the Northwest, at Northwest Ambulance Service, the Northwest Ambulance Service serve both Greater Manchester, Cheshire and Mersey, Lancashire and South Cumbria. So the Northwest Ambulance Service have a view of the GM care record, so they can directly access that shared care record. So if you imagine when you're in the ambulance in their control center, they have access to GM care record. They also have access to the similar views from Cheshire, Mersey, and from Lancs and South Cumbria, and that's all sort of integrated. Well, it's on the same piece of glass, if you will. What we're working through now is whether there's an optimized way of integrating that at a much more seamless level. So instead of it being represented as essentially in two windows, because Cheshire and Mersey have essentially the same technology to look at their integrated care record, and then the GM care record being another window, is technically, do we pull that together into the same window? So we're doing some work around that pace. And the key thing really is, it's less really about the technology, it's really about the information governance, about what you're sharing, about what reason. So we need to be absolutely laser focused about where there is, there is no clear, at the edges from a geographical perspective, there's a real blend of, where patients sit, and that's where we need to focus. So hopefully that answers the question that we're addressing the technical question quite pragmatically at the moment, so we've got the same shared care record available at the relevant points of access where we see those edge case boundaries, and then more broadly around data sharing across different regions. That then falls into the information governance question around what is the rationale for sharing that data, especially as we think about secondary usage of that data. Doug, the second question was around security of data, was it? Or
yeah, how can we ensure that the people that need the data can get safe access to the data?
Okay, well, I suppose there's two parts to that. So from a security perspective, we spend a lot of time ensuring that we're compliant to all NHS security requirements in terms of threat protection, in terms of people being able to break in and get access to that data. In terms of making sure that the right people are accessing that data, we have an audit process that tracks every access to the care records, so we know what every access is and what patient record they viewed. So a very clear auditable process. And as you go into the GM care record, you select what reason you're accessing that record for, and whether it's for COVID-19 or whether it's for other purposes. So we've got a really clear, robust set of capability. In terms of how we're ensuring does everybody that need access has access to it, I think we've some way to go on that journey. So I think we've got really good clinical adoption across, especially across key departments like A&E, as an example. We've got less adoption around other care settings that need access to that data, which will find it really valuable. And so what we're doing is building a program of engagement about how we really understand at each persona or user type group what they really need. So for example, from a care home perspective, it's really important the care home staff have access to a subset of that data. So what data do they need? From a pharmacy perspective, what subset of data do they need? So we are just about to launch a program of work which is specifically targeted at use of the data, which is much broader than just the secondary care usage or primary care usage, but includes the wider health and care sector, if that makes sense.
Yeah, no, absolutely. I mean, and that in its own right sounds like an enormous effort to be able to do just that. I mean, for others who are looking at trying to set up something similar within their system, what are the key things that you would flag? What are your key learnings about how you've gone about doing this and kind of rising to the challenge, coordinating digitally across, what do you say, 3 million people, 10 CCGs?
Yeah, 450 GP practices, 10 acute hospitals, 1 specialist hospital, 10 councils. Yeah, it requires. So yeah, I suppose my lessons learned will be, right, digitally, it's not about the tech. This is about a transformational journey. So, and as part of that, it needs to be absolutely interwoven into the service model transformation agenda of the ICS. digital cannot be seen as a tech thing that sits on the side. It actually needs to be absolutely interwoven into the service transformational journey. So to that end, digital really needs to have the buy-in at the top of the shop about its importance. So every conversation that we have around service transformation, whether it's elective transformation about cancer reform, whether it's about mental health, there is a digital component to that conversation. It can't be that digital sat aside. So making sure that it's owned at the top of shop, and really to enact the ownership at the top of the shop, you really need to build an effective governance structure. And we spent a lot of design thinking in terms of who needs to be on those boards and how those structures of the boards work. So at the highest level, we have a digital transformation board. On that digital transformation board, we have clinical, business, digital, and finance leaders on it. So it's chaired, for example, by the CEO of one of our acute trusts, and that chair is also shared by the head of the GMCA Council. So we've got a huge, leadership sort of element in there. And on the board, we've got representative from the provider network, so all second care providers, from primary care, from the accountable offices, from a council perspective. We have the chair of the medical executive that represents medical decision making across GM, and we have the lead representative for finance on in that group. So that gives us a very broad so really getting the governance absolutely interwoven is fundamental. I think the other key thing really is adopting an agile delivery methods, which really takes a sort of minimal viable product approach. You need to be able to deliver swiftly and quickly so that you can show that you're delivering value. And in terms of that sort of development of the MVP approach, you really need to sort of embrace the expertise of both, providers within the NHS plus academia plus industry, recognizing each of those different groups as a major part to play. And if you think around just in the mechanics of the amount of R&D investment that's available, if you just restrict it to the NHS, you're fishing from a reasonably small pool. If you extend that R&D investment and thinking to both academia and then to industry, the size of the R&D pool that you're leveraging is much greater. So having a inclusive approach to co-design with public and patient with those all those groups at the table is fundamentally in key. The final thing is availability of funding. So you do need to be able to at some point be able to execute, because you've got funding to be able to execute. Hopefully that gives you a whistle-stop tour.
No, absolutely. And I think that the approach and the importance of that kind of partnership, that collaboration, and in both in terms of bringing the different levels of expertise, bringing all the people around the table, and is going to be absolutely paramount going forward. I think we're almost out of time, so you've spoken very eloquently about many of the successes. I'd love to understand from your perspective what perhaps some of the biggest pain points and challenges have been, and what's given you most satisfaction on the journey so far.
Yeah, no, great. So I think most of a lot of the challenges around ensuring information governance and enabling that to occur at pace, because so that has been a real challenge, hand on heart, and maintaining the momentum and the trust of the data controllers, and ensuring that we don't fall back from under the coping notice. We everybody switches off data sharing and we're back to where we were. I think that getting in institutionally the structure in place to have that conversation has required some real heavy lifting, and there's still some way that we need to go around that. I see some of the comments in the chat in terms of the ability to execute on that. From a patient perspective, the feedback that we certainly get is that do you want the clinician to have all the information when they're making a decision, or do you want them to just be myopic, only have part of the conversation? So that's where we put a lot of heavy lifting around it. In terms of the things I personally got out of it, I think it's the patient stories that we hear in terms of the outcome that it's delivering to to people at the front end and for clinical care. You know, that we've got countless stories of clinicians writing into us, thanking us for the ability to access the care record, because they've made a different clinical decision to the one they would have done if they hadn't had that information. We've also, you know, had people that, you know, again, writing into us to thank us for, because the care record shows COVID status, about them changing about whether they go and see a patient and how best to engage with that patient, because they've got active real-time information about COVID status. So I think it's those patient stories that really sort of resonate with me about what makes it real, and why we get up in the morning to do all the things that we're doing.
Brilliant. I think that's a perfect place to wrap up the benefits to patients that this can bring. Guy, I could speak to you around this topic for a very long time. Thank you so much for sharing your insights. And a big thanks to the audience for the questions, the interaction, and the comments throughout.
Great.
So many thanks to everybody, and enjoy the rest of the session. Bye-bye.